Yes, today I'm going to present heart failure. My objectives for this presentation is to know the epidemiology, etiology, and pathophysiology of heart failure, the clinical signs and symptoms of heart failure as they manifest in older adults, appropriate management strategies, and how to provide end-of-life care with consideration of individual patient prognosis. The topics covered include epidemiology, etiology and pathophysiology, clinical features, diagnosis, management, recurrent hospitalization, prognosis, and end-of-life care. First, I'll start with the epidemiology of heart failure. Incidence and prevalence increase with age, as it's well known that age is an important risk factor. It's actually one of the most common risk factors in heart failure, which leads to hospitalization and rehospitalization in older adults. So the geriatric population is especially affected by heart failure. The median age of patients hospitalized with heart failure is 75 years, and approximately two-thirds of death attributable to heart failure are in patients aged 75 years or older, so they are the most vulnerable population in this disease. Heart failure is a major cause of chronic disability and impaired quality of life in older adults, of course. Heart failure in older adults is often multifactorial in origin. There are no one single factor that we can attribute heart failure to. Hypertension is the most common antecedent cardiovascular condition in both men and women. As we all know, hypertension is a very common disease. Almost near half of the population are hypertensive. The principal cause of hypertension is 60 to 70% of women, and in men it's 30 to 40%. Uh, and a similar proportion is attributable to coronary artery disease, which is also another common risk factor of heart failure, causing ischemic heart disease. Of course, the pathologies may differ from ischemic heart disease, which most commonly causes a systolic heart failure, and hypertension being a common cause of diastolic heart failure, meaning the heart problem is that the muscle is too stiff and it takes a lot of proportion of the cavity of the ventricle. So it's mainly a diastolic problem. Other common causes include valvular heart diseases and non-ischemic dilated cardiomyopathy. The special thing about non-ischemic dilated cardiomyopathy is that it's also caused by many other risk factors, including alcohol and viral diseases. This is why we may see some young patients experiencing dilated cardiomyopathy, not ischemic. Ischemic is more common in the older population. Systolic heart failure, which is heart failure with reduced left ventricular ejection fraction. This is up to 90% of patients under 65, and it's the most common cause of heart failure. Heart failure with preserved ejection fraction, which is ejection fraction more than 50%. This is what we call the diastolic heart failure. It affects 40% of men and two-thirds of women more than 65 years of age. Symptoms and signs of heart failure in older patients. Heart failure is relatively easy to diagnose clinically. There are some sensitive signs that could lead us to diagnose heart failure, but it's often atypical and non-specific. They might be sensitive, but it's non-specific. This is why we need to go to investigate the patient. The most common being exertional shortness of breath, fatigue, orthopnea, and leg edema. Exertional symptoms may be less prominent in older adults because of a more sedentary lifestyle. Prevalence of atypical symptoms increase with age. Decreased mental acuity, confusion, lethargy, irritability, anorexia, abdominal discomfort, or altered bowel function are all atypical symptoms that they increase with age. So, diagnosis of heart failure. Standard chest radiograph remains the most useful initial test for detecting pulmonary congestion and pleural effusion. Um, it's a very sensitive sign to indicate that the patient has pulmonary edema. It also excludes pneumonia, which may have a similar presentation to heart failure, excluding the fever, and that pneumonia relatively have a shorter course of duration than heart failure. A patient with pneumonia can have severe symptoms in less than a week or two, while heart failure is a more chronic illness. So the timeline of disease is very important here to differentiate between these two illnesses. B-type natriuretic peptide and its precursor N-terminal pro-BMP are valuable in establishing the presence of heart failure and in particular in distinguishing shortness of breath due to heart failure from that attributable to non-cardiac causes, but specificity decreases with age. It's a very sensitive test. It's very useful in excluding heart failure, but it's not specific. So we don't use it when uh, to establish a diagnosis of heart failure. We use the other investigations and signs and symptoms that are more specific than BMP. So management of heart failure. The goals are to decrease symptoms and improve quality of life, reduce acute exacerbations requiring hospitalization, and increase survival. Hypertension, hyperlipidemia, and diabetes should be treated in accordance with current guidelines. Smoking cessation should be strongly encouraged and supported if indicated, and alcohol intake should be limited to no more than 2 drinks per day in men and 1 drink per day in women. So, management of heart failure. Uh, there are many drugs that are approved for management of heart failure now. Some of them decrease mortality, while others decrease hospitalization rate and symptoms. Uh, but when we manage a patient with heart failure, we need to look into all the different risk factors, including smoking and drinking, and also lifestyle modification, and to also pay special attention to comorbid conditions. We need to control diabetes and control hypertension, of course, as both of these diseases are well known established risk factors of heart failure. There are also non pharmacological therapy, an example of which is to restrict dietary sodium intake into less than 2 grams per day. Most patients with heart failure should also engage in regular exercise, such as walking, stationary cycling, swimming, or water aerobics. Exercise duration and intensity should be adjusted to the individual patient's level of conditioning, severity of heart failure, and comorbidities. And patients should keep an ongoing record of their daily weight because weight is a very sensitive way of measuring uh, the overload state in heart failure. Pharmacotherapy of systolic heart failure. Optimal treatment usually requires more than 3 medications and in some cases up to 7. And usually in heart failure medications, let's name a few, for example, ACE inhibitors, angiotensin receptor blockers, or spironolactone, which is an aldosterone antagonist. We also have the diuretics, of course, furosemide. These medications and beta blockers, of course, diuretics furosemide does not decrease mortality, but it decreases symptoms. But all the other drugs I've mentioned, beta blockers, ACE inhibitors, ARBs, and aldosterone antagonists, decrease mortality in heart failure. We usually start these medications with a low dose and we titrate the to reach the target dose of each. So the target dose is very important to reach because although these drugs decrease mortality, they decrease mortality more so when given in the appropriate dose. Almost all patients take more than one additional medications for coexisting illnesses. Of course, we know that heart failure patients always have other comorbidities, or most of the time they have other comorbidities. Problems include adherence, high potential for drug interactions and adverse events, and finally, cost. Uh, there's a lot of uh, um, adverse interactions and side effects caused by heart failure medications. AC inhibitors are quite commonly known for causing cough, so we always need to educate the patient when prescribing this medication, in if what to do if he developed or she developed a certain symptom. Therapy must be individualized, taking into consideration the multiple factors that influence quality of life and other desirable clinical outcomes in older adults with multiple chronic illness and limited life expectancy. AC inhibitors for systolic heart failure in general start treatment at the lowest dosage and gradually titrate to maintain dosage as tolerated. As I've mentioned earlier, we have to reach the target dose of each medication to reach its optimum ability to decrease mortality. Contraindications include known intolerance, hyperkalemia, uh, and severe renal insufficiency in patients not currently undergoing dialysis. Well, AC inhibitors, as I've mentioned earlier, you need to educate the patient before starting the medication about the cough. We also need to look at the renal profile of the patient because there are certain contraindications to using AC inhibitors, which include the bilateral stenosis of the renal artery. Common adverse events include cough, which is 5 to 10% of patients during long-term treatment, mild worsening of renal function, which is often transient, and then it decreases, hyperkalemia, hypertension, and GI distress. ARBs are an option for heart failure patients unable to tolerate AC inhibitors because of cough, allergic reactions, or GI disturbances. Beta blockers for systolic heart failure. As with ACE inhibitors and ARBs, treatment should be started at the lowest available dosage and gradually titrated to the maintenance dosage over several weeks. Contraindications include severe decompensated heart failure, active bronchospastic lung disease, marked bradycardia, relative hypertension, AV block, and known intolerance to beta blockers. One thing I need to mention here is that not all beta blockers decrease mortality in heart failure. There are certain medications that we use, which includes bisoprolol and carvedilol, and also metoprolol. These are drugs that are known to drastically decrease the mortality in heart failure, and they're all selective beta blockers, so we don't use non-selective beta blockers in heart failure. And also, an important thing to know about beta blockers in heart failure is that in the acute setting, which is in a decompensated patient, we do not use beta blockers. It's a relative contraindication to using it. We first offload the patient using diuretics and ACE inhibitors, and then we start beta blockers a few days after the patient is stable. This is in the case of severe pulmonary edema, which is decompensation of heart failure. Diuretics are an essential component in most patients, most effective agents for relief of congestion and edema. In general, the diuretic dosage should be adjusted to maintain euvolemia, manifested by the absence of pulmonary rales and S regurg, increased JVP, hepatojugular reflux, and peripheral edema. So, aldosterone antagonist. The aldosterone antagonist spironolactone has been shown to reduce mortality in hospitalizations in patients with New York Heart Association class 3, 4, and patients with left ventricular ejection fraction less than 30%. So spironolactone is most effective in the most ill patients, uh, meaning the patients with the most decompensated state. The selective aldosterone antagonist eplerenone has been associated with improved outcomes in patients with recent MI complicated by heart failure or left ventricular ejection fraction less than 40. There are other therapies, of course. Digoxin improves symptoms and reduces heart failure hospitalization in patients with chronic systolic heart failure but has no effect on mortality. Adverse events include nausea, visual disturbances in the form of yellowish discoloration, and cardiac arrhythmias. The combination of hydralazine nitrates is recommended for patients with contraindications to ACE inhibitors and ARBs in Black American patients, as it has been found that Black American patients Black Americans or Africans in general typically have a better response to hydrolazine and nitrate, with advanced heart failure as an adjunct to ACE inhibitors and beta blockers. I also would like to mention that digoxin is well known for its toxicity. It has a very low therapeutic index. So we have to be very careful when prescribing digoxin and we have to pay attention to these adverse events, nausea, visual disturbances, and arrhythmias, of course. Pharmacotherapy for heart failure with preserved ejection fraction. Optimal therapy remains undefined. Current recommendations are to aggressively treat hypertension and other risk factors. As we mentioned, it's very important to look at the comorbidities and treat each, manage the comorbid uh, coronary artery disease, maintain sinus rhythm or effective rate control in patients with atrial fibrillation, judiciously use diuretics to maintain euvolemia while avoiding overdiuresis. As many of these patients are volume sensitive, they are quite volume sensitive, so we need to be uh, very careful when using diuretics in patients with preserved ejection fraction. Implantable cardiac defibrillator. They reduce mortality from sudden cardiac death in patients with systolic heart failure and left ventricular ejection fraction less than 35. These are the most ill patients, regardless of ischemic or non-ischemic heart failure. Prophylactic placement is advised for patients with NIHA class 2 or 3 or when left ventricular ejection fraction is less than 35 and life expectancy is more than 1 year. These are clear indications for prophylactic placement of cardiac defibrillator. Defer implantation for more than 40 days after acute MI and more than 90 days after new diagnosis of dilated cardiomyopathy. In the latter case, because left ventricular function often improves after initiation of beta blocker and ACE inhibitor, so we need to give a chance to medical therapy first to see its result, and then we decide if we want to implant a cardiac defibrillator. Cardiac resynchronization, a biventricular pacemaker with one lead in the right ventricle and a second lead inserted retrograde into the coronary sinus to stimulate the left ventricle, indicated in patients with dysynchronous left ventricular contraction. Most commonly related to left bundle branch block, it's present in up to 30% of patients with systolic heart failure. Improves symptoms, exercise tolerance, quality of life, and survival in selected patients with advanced systolic heart failure and persistent severe symptoms despite conventional medical therapy. Recurrent hospitalization. Up to 50% of patients with heart failure are readmitted within 3 to 6 months after the initial hospitalization. Patients with heart failure are generally have a very high rate of readmission. They usually decompensate and come back for a lot of reasons. Um, Patients who experience recurrent heart failure hospitalization within 3 to 6 months after an index admission should be questioned carefully to see what is the reason for this decompensation. Is it adherence to medication? Is it recent change in weight, recent dietary choice, or daily fluid intake? So we need to pay careful consideration to these factors when assessing patients who are readmitted with heart failure. The median survival rates of 2 to 3 years. 25 to 30% of patients die within 1 year after initial diagnosis. 50% survive 1 to 5 years. This has not changed for quite a long time now. 20 to 25% survive more than 5 years. Women and patients with high uh, ejection fraction have somewhat better survival rates than men and patients with systolic heart failure, which is low ejection fraction. So high ejection fraction have in here the best prognosis compared to the systolic, which is low ejection fraction. Of course. The ejection fraction rate here, which is preserved ejection rate, we, we say it's a preserved ejection fraction when it's more than 45%. End of life care. Counsel regarding an advance directive, durable power of attorney or healthcare, and explicit instructions about what interventions they would or would not wish to undergo if death appeared imminent. Ask patients with ICDs to indicate under what condition they would want the ICD turned off to avoid repetitive painful shocks at the end of life. In patients with particularly poor prognosis and remaining life expectancy less than 6 months, frank but empathetic discussion should be undertaken with the patient and family. So, in summary, heart failure is the leading cause of hospitalization in older adults and a major source of chronic disability. Older patients with heart failure are more likely to be women and more likely to have preserved left ventricular systolic function. AC inhibitors, ARBs, beta blockers, and aldosterone antagonists reduce morbidity and mortality for heart failure with reduced ejection fraction. Optimal medical therapy for heart failure with preserved ejection fraction is undefined yet. Optimal, what do we need to pay special consideration to comorbid conditions? That what we can do now. Optimal management of heart failure in older patients often requires a multidisciplinary approach. So, case one. A 78-year-old man with no significant medical history comes to the emergency department with severe chest pain of 3 hours duration associated with shortness of breath and diaphoresis. Initial ECG findings: 4 to 5 millimeter ST segment elevation in pericardial leads V2 to V5 and 1 to 2 millimeter ST depression in limbs 2, 3, and AVF. Emergency cardiac catheterization reveals 100% occlusion of the LAD just after the first large septal branch. Precutaneous coronary angioplasty with insertion of stent into the LAD artery is successful. Peak troponin level is 8.6. The hospital course is complicated by mild heart failure that resolved with diuresis. Pre-discharge echo reveals anteroapical hypokinesis with mildly decreased left ventricular systolic function and estimated ejection fraction of 45%. On day of admission, the total cholesterol was 186, HDL 47, LDL 113, and triglycerides 130. In addition to aspirin, a statin, and clopidogrel, which of the following are appropriate discharge medications for this patient? Is it beta blocker and long-acting nitrate? Is it beta blocker and spironolactone? Is it non-dihydropyridine calcium antagonist and ARB? Is it beta blocker and ACE inhibitor? Or is it non-dihydropyridine calcium antagonist and long-acting nitrates? You can look uh, for the case, and if you have any suggestions for the answer of this case, you can send it, of course. But for the sake of this presentation, this a 78-year-old man with ST segment elevation and depression in the 2-3 AVF, depression in the 2-3 AVF pretty much states that this patient has an inferior myocardial infarction. We did all the catheterization, which revealed 100% occlusion of the LAT. The percutaneous coronary angioplasty insertion of the stent to the LAT is successful. His troponin is quite high, which means it's an ischemic cause. The hospital, which goes along also with the ECG changes, the hospital course is complicated by mild heart failure that's resolved with diuresis. His ejection fraction is 45. So, beta blockers and long acting nitrates. Well, beta blockers are known to decrease mortality in ischemic heart failure. So, it's a possible answer. Nitrate is effective at decreasing the symptoms and hospitalizations. So, it's also A, we can consider A for now. Beta blockers and spironolactone. Well, we've said earlier that spironolactone is effective when an ejection fraction is less than 35. So this is the most effective when it's less than 35. This patient ejection fraction is 45, so we don't need that now. Non-dihydropyridine calcium antagonist and ARBs. ARBs are, yes, are quite useful in ischemic heart disease. They decrease mortality significantly, but do we need non-dihydropyridine calcium antagonist at this stage? Beta blockers and ACE inhibitors, non-dihydropyridine calcium antagonist are long-acting nitrates. So we're going to go with the beta blockers and ACE inhibitors. If you have different thoughts, you can send them to me. Both of these drugs decrease mortality and they are indicated for every patient with ischemic heart disease. So it's a very potent uh, combination. As you can see, the answer here is B. beta blockers, and ACE inhibitors. So, case 2, 74-year-old woman comes to the emergency department with palpitations and shortness of breath of 2 hours duration. Her history includes hypertension, mild restrictive lung disease, gastroesophageal reflux disease, and positional tremor. She says she was sitting in a chair when she noted the sudden onset of heart racing, followed a few minutes later by difficulty breathing. She reports no chest discomfort, diaphoresis, dizziness, or syncope. When the symptoms did not resolve after an hour, her son brought her to the emergency department. So here we have a 74-year-old woman who came to the emergency department with palpitation and shortness of breath for 2 hours. She has hypertension, restrictive lung disease, and gastroesophageal reflux disease, and also tremor. She says she was sitting in a chair when she noted the sudden onset of heart racing, which is the palpitation, followed a few minutes later by difficulty breathing. So palpitation followed by difficulty breathing. She reports no chest discomfort, diaphoresis, dizziness, or syncope. When the symptoms did not resolve after an hour, her son brought her to the emergency department. On examination, the patient has mild respiratory distress. Her heart rate ranges from 130 to 150, which is tachycardic and it's irregular. Her